You can start.
Yes.
You can speak.
Yes. Good evening, everyone. Myself, Dr. Prerna Mishra. I'm DNB resident at Somaya Medical College, Mumbai. Today, I'm going to present a case on ocular trauma. It's an emergency. My patient, 29-year male, working at construction site, he presented with chief complaint of trauma to the left eye, diminution of vision, and trauma to the left eye associated with pain, foreign body sensation, watering, redness, photophobia since 3 days. He had having history of iron nail trauma, after which he had diminution of vision, which was sudden in onset associated with following complaints. No history of any other ocular surgery in past. The ocular examination, the past history, he not having any complaint of any systemic diseases, and no history of any drug allergy. The general examination is within normal limit, systemic examination is normal limit, and ocular examination of right eye, the anterior segment examination is within normal limit, but in the left eye, the patient developed vision of best corrected visual acuity of 6 by 36 with cornea involvement and limbal tear at 7 to 8 o'clock position and scleral tear at 3 to 4 mm with iris tissue prolapse at 7 to 8 o'clock position. The fundus examination of right eye is within normal limit, but the left eye only red glow had been seen. The systemic examination is within normal limit. My final diagnosis was left eye penetrating type full thickness scleral tear involving limbus at 7 to 8 o'clock hours with iris tissue prolapse. The surgical management was done and the scleral limbal tear repair done with 10-0 nylon under local anesthesia. The post-op best corrected visual acuity of the patient is finger counting close to face. After 1 month, the patient developed lenticular abscess with vitreous exudate. The picture showing this lenticular abscess. Then we done the further management, plan for left eye cataract extraction with intraocular lens implantation with intracameral antibiotics under local anesthesia under guarded visual prognosis. In this way, we done the cataract extraction and intraocular lens implantation. After 1 month, the patient presented to the OPD and he is having vision, he had having vision of best corrected visual acuity of 6 by 18. My conclusion is a good cataract extraction with intraocular lens implantation with intracameral antibiotics allow control of infection with good visual prognosis. These are my references. Thank you.
Okay, you mentioned with an intraocular implant, you can control the infection.
Yeah.
It is infection or inflammation?
Sir.
Because in case of a, suppose in case of a infection,
Yes, sir.
IOL or any type of cataract operation is a contraindicated.
Yeah.
Okay.
Yes, sir.
So your, as per your statement, you mention it, it is a infection. Is it infection?
Yes, sir.
What about
Sir.
how you manage intracorneal
Yeah.
part?
So we done the lenticular abscess extraction, and we done the intraocular lens implantation by giving the followed by intracameral antibiotics.
Whatever antibiotics, so before, okay, you are empirically
Van-
you are giving
yeah.
antibiotics, but ideal, this is not the ideal procedure. Ideal
sir.
procedure is you can take a corneal scrapping corneal materials and you can send for culture and sensitivity, and then accordingly you can send it. It's not working. It's not working. You can send it for culture and sensitivity. That's a one point. Second, this is in the management, in always in trauma, this is a take-home messages we should be under general anesthesia.
Yeah.
This is mandatory. It should not be under a local anesthesia. From the first onwards, there is some problems there. You are intracorneal abscess and you are injecting air. May I know your by what method you are injecting air in the AC? So there is other options are that you can maintain the AC or you can form the AC by other substance also, liquid,
Yes.
fluid or whatever, but you are injecting air. Of course it is easy, but with the air there may be some other issues. There may be infection in the AC,
Yes,
there
sir.
may be intracorneal abscess, there may be inflammation, so many points, there may be endothelial injury.
Yes, sir.
So why you inject air?
Just to prevent the collapse of anti-chamber formation.
Anterior segment formation ideally is not the air.
Okay.
And if it is air, suppose you want to inject with air, then what will be your method? To inject air, what are the precautions you should
So
take care?
yeah. Not to damage the anything in the
No.
eyes.
No. What is the ideal to inject anything inside the eye? It may be a C3F8, it may be aseptic, or it may be a normal air. What is the method?
So surgically we put
This is our practice, is day-to-day practice. That's why day-to-day practice we are just injecting that. This is not the correct method.
Also.
What is the correct method? So just I am highlighting, so for any injury cases, if we want to form the AC by air any cost, in such scenario, that thing is the filter, air filter. We should use the air filter. Is autoclave air filter is the only option, because we should not, the room air should not enter in the AC one. If any case, if there is a room that air filter is not available, in such cases, next option is that in a good condition, you just with capping of the, then we can draw a filter, so we can protect little bit of.
Okay.
You can just around the gauze, we can sterile gauze, we can around that needle and cap, then you can pull, then you can withdraw, then with a sterile 23 or 24, whatever, we can inject the air. That's another option.
Yes.
Ideal is that we can go use a sterile solution. That's the reason. Once your air filter is not available, only in few cases in a very lacerated cornea, where it's not possible for you to all injury, in such cases torn, sutured, in such cases only we need air, because retention time is air is more than in fluid.
Yeah.
So that's the reason. Once there is edema will subside that or take over, then there is the only options. So we should not, first we can try for a, we need a that one. So the take home message is like that, and never, until and unless lenticular rupture, we should not go for cataract extraction in a straight way, please. Straight way.
Okay.
So our aim is to always to assess slit lamp or whatever way methodology, and accordingly we can do. Second is that we should not go in a hurry, and then definitely for your, if any chance of there is a inflammation, we should not go for a cataract. But your patient is lucky, you are lucky, that's why there is a good outcome.
Yes.
Otherwise, patient may land up with endophthalmitis, and it will be very, very difficult to save the eye.
Okay, sir.
Any questions? Dr. Prasenjit, you want to add something regarding, when you are doing assistant professor, so you are doing facing so many cases every day. Okay. So, thank you.
Thank you,
So
sir.
those are some take
Yes,
home
sir.
messages. Yes.
Okay, sir. Thank you so much.
Next speaker is Alok.
Alok, Dr. Alok.
Alok is not here, I can see. Dr. Praveen Kumar,
Yes, please.
what is his presentation? Fungal orbital cellulitis by Candida albicans following a snake bite.
Good afternoon to all. My case is fungal orbital cellulitis by Candida albicans following snake bite, a rare case. Since we all know that poisonous snake bite is a medical emergency because it involves the multi-system, and whereas the orbital cellulitis is an ophthalmic emergency, orbital cellulitis is basically the infection of soft tissue surrounding the orbit. Fungal orbital cellulitis is basically will be in immunocompromised individual, usually in immunocompetent individual, usually it not happens. So my case is a 10-year-old male which presented to the emergency department with low-grade fever, malaise, nausea and vomiting with drowsiness. He was having history of snake bite over right upper lid while playing 8 hours prior to the presentation, and he received first aid in the form of local wound incision locally. There was no sign of internal and external bleeding and no sign of no significant prior history of illness. On examination, patient was having low-grade fever of 100 degree Fahrenheit. Pulse was 108 beats per minute. BP was 90 by 68 millimeter of mercury and respiratory rate was 26 cycle per minute. He was having altered sensorium. On ophthalmic examination, right eye lid was having a periorbital edema with skin necrosis with mechanical ptosis. Extraocular movement and visual acuity could not be assessed because patient is in altered sensorium. Conjunctiva was having congestion and chemosis. Cornea was clear, anterior chamber was normal depth, and pupil was briskly reacting. Lens was clear and fundus was normal, and IOP with eye care was 18 millimeter of mercury. In the left eye, anterior and posterior segment was within normal limit. So provisionally, we came to the diagnosis of right eye preseptal cellulitis following snake bite. Patient was admitted to PICU, and anti-snake venom injection was started with injection ceftriaxone, antibiotic eye drop in form of moxifloxacin and moxifloxacin ointment. On systemic evaluation, there was no evidence of immunocompromised status. Hemoglobin was normal. There was leukocytosis, and blood sugar was 98 milligram per deciliter. Renal function, BTCT was normal. HIV and HBsAg was not reacting, and blood culture was sterile till third day. On second day of admission, patient was deteriorated systemically and was unable to maintain oxygen saturation, and patient was intubated. And also ophthalmologically also patient was deteriorated. Patient developed proptosis with 22 millimeter in the right eye with 16 millimeter in the left eye at 95 millimeter at Hertel's ophthalmometry, exophthalmometry. On lid, there was worsening of the periorbital edema and skin necrosis. Conjunctiva, chemos and congestion increased. Anterior chamber was normal depth but quiet. Pupil was 4 millimeter dilated and sluggishly reacting, but fundus was normal. So CT scan was done on the same day, and there was collection of the preseptal area with intra and extracoronal space in the superior portion of the right orbit, and there was inferolateral displacement of the eyeball. Incision and drainage of that inflamed area was done, and pus was removed, and there were, we did wet mount of the pus. There was pseudohypy with budding cells was there. In the germ tube test, Candida albicans was identified. On several dextrose agar culture, yeast-like colony, which was confirmed by Gram staining. So we came to the conclusion that the patient is having Candida albicans infection. So a confirmatory diagnosis, we came to that he was having fungal preseptal cellulitis along with orbital cellulitis of the right eye following snake bite. By that etiology is Candida albicans. Patient was started on injection ephedrine B and natamycin eye drop with cotrimazole ointment. On fourth day, proptosis and periorbital edema started decreasing, but unfortunately on fifth day, patient deteriorated systemically and succumbed due to the respiratory failure. So poisonous snake bite is having multi-systemic toxicity, but various case report has shown the ocular involvement following snake bite. Other ocular involvement are angle closure glaucoma, acute anterior uveitis, optic disc edema. There may be the direct injury to the globe causing the open globe injury. There may be the conjunctival and corneal laceration. There may be endophthalmitis, vitreous hemorrhage and exudative retinal detachment. But fungal orbital infection are rare, and till now there is no cases reported so far. So possible reason of the fungal orbital cellulitis in our case may be the direct inoculation of the fungus in the preseptal and postseptal area. There may be the host inflammation in the response to the fungal infection from the conjunctival cul-de-sac, and there may be the concomitant systemic instability with antibiotic use, but there is no conclusive evidence of any of these theory. So fungal etiology should be kept in mind while treating orbital cellulitis patient following trauma, including snake bite, and immediate suspicion with early microbiological diagnosis and prompt treatment are essential in the management of such type of cases. Thank you.
You said that fungal endophthalmitis is not reported in the literature.
Fungal orbital cellulitis following snake bite is not reported.
Following snake bite,
Yeah.
because fungal or
Fungal is there, but following snake bite is not reported.
And where was the snake bite? Which part of the body?
While patient was playing, he fell down. At the same time, snake bite happens on the upper part of the lid.
That you should have told.
I,
You said snake bite, snake bite. So snake can bite anywhere.
it was there in the
Snake can bite anywhere. So this and the other thing was the treatment for snake bite initiated at the same time.
locally at when patient was admitted to the hospital, then it was
Which hospital the patient was admitted?
at Jipmer, Pondicherry. Jipmer, Pondicherry. Yeah.
Jipmer.
Yeah.
Oh, you are here in Center for Sight, no?
Currently now center of sight.
Center for Sight. So I was just trying to relate because I thought that maybe it happened here in Patna only.
Yeah.
So, but you mention here preseptal cellulitis.
Yeah.
But it looks like orbital cellulitis. So,
Yeah, initially-
no, whatever way, if you are not confirmed, but as per your representation on CT, it is a huge collection and it is a proptosis like that. From clinical presentation, a full orbit is involved. So you should not utter that word preseptal. Preseptal is only preseptal. There is a definite characteristics point is there for preseptal. And orbital, there is some movement problem, everything is there. So better you can say is a orbital cellulitis. You are in a safe mode.
Yeah.
No problem. Good, good.
Thank you, sir. Thank you.
Yes, sir.
It's ready.
Sorry, sir.
Okay.
Another session in the.
Yeah.
Busy man.
No, not busy, sir.
Are you going to show some videos to us?
Just one video. Just one case. I thought this was a case presentation. Yeah. So shall I start? Yes, sir. Thank you so much. So I'll be sharing one case that came across at Chitrakoot and just sharing some of the challenges that we had while managing this case. So this case was a 20-year-old male who had a blast injury due to bonfire about 4 days back before he reported to our cornea department with this sclerocorneal tear, and which was repaired there, and then he was referred to vitreoretina department because he also had vitreous hemorrhage and ifema, which you can see here. So when we saw the patient, we did an X-ray, and you can see this large sinusoidal foreign body in the left eye, and even on the B scan you can see this a localized choroidal detachment, but some foreign body which was protruding, although we could not get a very good B scan here. I'll just go to the video. So since it was a large foreign body and there was already cataract that was set in, we decided to do lensectomy. And once we completed the lensectomy, we proceeded with the vitreous surgery. There was dense vitreous hemorrhage, which was gray. And at this point of time, we could not localize the foreign body. So it was a huge foreign body on B scan and on X-ray, but we were unable to localize initially where the foreign body was. So after inducing the PVD, we completed the co-vitrectomy. You can see little amount of subretinal bleed was also there. At this point of time, I accidentally happened to touch this with the cutter, and you can see this large foreign body protruding into the vitreous cavity. Right, so at this point I decided that it was very difficult to remove it from inside the eye, so I decided to explore, and we tried to explore the area, and you can see this, there was a scleral wound, and we could remove this foreign body, negotiating slowly through that wound. Now the next challenge was to seal this wound, so what we decided was to do a compressive suture using using the tenoconjunctival flap, because I wanted to complete the vitreous surgery as well. So we did a compressive suture so that this wound seals and we can complete the procedure further. Then we went ahead and did a thorough complete vitrectomy, did the waist dissection. What we noticed was, as you can see, there was a localized choroidal detachment and there was no retinal break as such. This had come through the pars plana area. So what we did was we just did a fluid air exchange and left because I had some doubt that the wound might leak. And this is the post-operative picture of the same patient. At 6 months, the vision had improved to 6/9, and we did an SFIL in this patient. Thank you.
Excellent, Dr. Alok. Very nice. Very initiative way.
Sorry, sir?
You were lucky that,
Just long.
Scleral wound, right?
so that's good. Go to the next.
Yeah, next time.
Yes.
Yes, sir. Yes, sir.
You're from Calcutta?
No, sir, from Guwahati.
From Guwahati.
Guwahati, sir.
I love this place.
Yes, sir. Yes, sir. So, so everyone in the indirect carotid cavernous fistula in is a key, and ophthalmologist is the first to diagnose it. I don't have any such financial disclosure. And those are some theoretical point I don't want to say. It is first published in 1930, not too much long. So those are the points. So some are very, very easy. Those are the vascular malformation, carotid cavernous fistulas are easy, but some are very difficult. I want to highlight one of my patient. This particular boy, he was operated. He is a brother of one of the neurosurgeon, and he is a relative of one of the plastic surgeon. Both of them operated from my hospital. So he was operated. He was in unconscious mode for 2 hours. He was admitted in ICU, and whatever, there is a little bit of mild frontal lobe injury and parietal lobe injury, whatever fracture was there. He was repaired, flattening was done, nice, done, everything. But the mistake was done that day. Once he came for review one day, as he is also, his father is on my patient, so once along with his father he came, he is telling, sir, I am also feeling some amount of dull ache in the eye. Then I asked to go for a full checkup. Then when I examined, his eye was little exo. Then okay, whatever. Then I asked that thing, okay, it may be due to some injury. But interesting part was the IOP was high. Then when I examined the slit lamp, there's a corkscrew appearance in the left eye. If you observe in the left, there's a corkscrew appearance. He underwent lots of several CT scan, etc., pre, post, whatever, but it was not detected. Then I did immediately gonioscopy. And gonioscopy, there was a little bit of blood in Slem's canal. Then I identified it as CCF. Okay. So CCF, all hallmarks. Of course, I did with a bail of the stethoscope, I just examined the patient. Then there's a bruit was there, very faint bruit is indirect. I almost confirm there is some paresis is there in the muscle. IOP was 28 to almost 30 in between. Then those are the points. Deviation, gonioscopy, history about you, we make the fixer with flatting. The big question is, though I am diagnosed is a CCF, all other previous CT scan, it was fine, normal. That doing plate is in situ, those fractures are repair, healing, everything. No sir, muscle entrapment, brain is normal, okay. But as we know that the investigation of choice for CCF is to confirm or to diagnose or to treat. Confirmation is the MR angiography or MRI. Then I decided to do it myself. I did one ultrasound, and there is a superior ophthalmic vein, comma shape, superior ophthalmic vein that is, and then I almost confirmed, but this is not enough to treat. because the lesion is in the cavernous sinus, leak is in the cavernous, it's not in our part. So it is in some other places. So I want to convince my neurosurgeon and my anesthesiologist to I does that idea. Then question is that plating, everyone is refusing, well, I will not go for it with plating, MRI. Then next option what? Then option is CT angio. CT angio reason is that though I know if that plating, the angio CT is required, but we don't know that any screw is loose or not. If during plating any screw is loose, so it may create some problem with MRI. That's the reason I just advise, just 1 minute, advise MRI and initially CT angio confirm or in situ, then we did that is the treatment is the embolization coiling. So coiling was done and it was that feeling pattern. You can see the feeling pattern. In presence of the neurosurgeon. So then once it's feeling over, then that's the reason I want to say one point, paramount necessity is a thorough history. Detailed examination, there's no shortcut in examination. MRI, CT, angio is the choice of imaging technique, not in others. Take-home message, ophthalmologist may be the first to encounter the patient with a clinical manifestation of CCF, and the present paper will help to understand the clinical features, current diagnostic approach, possible modes of treatment and outcomes. Thank you.
How much was the proptosis in your case?
No, sir, it was a indirect CCF late, no proptosis, sir. His present was only dull pain and there is a little exo. It may be due to he thought it may be due to the injury itself because there is a fracture. What? IOP was high, blood in the Slem's canal, and just the only in orbit is dilated superior ophthalmic vein in ultrasound. Nothing.
Normally proptosis is there.
They are in case of a sir, high volume.
And clinically, proptosis is compressible.
Yes, sir. In
Compress, this means this is because of carotid cavernous pressure.
yeah.
If it is not compressible, then some other cause is there, which is, from behind. Bilateral, exophthalmos, if it is compressible, it is carotid cavernous pressure. But maybe in some
Yeah.
cases it may not present like that.
Yeah, there may be a variation, and next is
very good.
especially if it is a low grade. If it is low grade and small, then IOP may be one of the, or some amount of little bit of intracranial pressure inside the brain may be one of the presenting finding. There may be some unusual presentation. Thank you, sir.
Dr. Jayant. The next presentation is Dr. Muhammad Raghib Tohid. Is he here? No. So the next presenter is Dr. Kajal Pal. Is she here? Oh no, that's good. So we have before time. So whosoever is speaker here, please come. Present, we will take the picture. Speaker.